everyone, and welcome to our webinar today. My name is Chloe Setsos, and I am the Program Coordinator at Capital Link, and I'd like to thank you all for joining us today. I will be running technical aspects of this webinar. In just a moment, I will turn this presentation over to our panelists for future introductions. But before that, I have a few small housekeeping items that I would like to run by with you. Because we have such a large number of participants on the webinar today, everyone joined will be in muted mode and will remain so through most of the webinar. However, you will be able to unmute yourselves to ask questions at several points during the presentation and in the office hours that will take place right after the presentations. On your sidebar of this platform, you should all see in the list of drop-down options a space entitled Questions. If throughout the webinar you do have questions, please type and send it in that space. There will be a very brief survey that will launch at the end of this webinar. Your participation in this survey is greatly appreciated. It will take about 3 minutes to fill out. We also do have a handout section that has one handout prepared for you today. And one of those are key terms documents for your reference. Last but not least, if we encounter technical difficulties on our end or yours, do not worry. The audio is available to all registered participants after this webinar concludes. Without further ado, I will now pass it to Allison Coleman, CEO at Capital Link, to kick off the presentation.
Welcome, everybody. I'm glad you're able to join us today. And Chloe, if you can advance the slides. You can go to the second slide, please. Want to welcome you to the SDOH Academy. There are 4 learning collaboratives that we are doing in 2020. Health centers and PCAs and HCCNs are the main target market. Many of you have signed up for multiples of these sessions. And all of the recordings of all of the sessions are available on the Academy website. Chloe, please go to the next slide. This is just a quick overview of the faculty for the SDOH Academy. You see that there are 16 organizations that all have national cooperative agreements with HRSA that are participating, with 5 of the organizations leading the steering committee and helping to shape the overall framework for the annual sessions. Next slide, please. These are the 4 topics covered in 2020. There are really 4 sets of topics with 2 webinars each. Today's webinar is the second webinar in the 3rd series of learning collaboratives focused on community partnerships. Next slide. All of the learning collaboratives strive to address 4 core competencies. Today's session mainly focuses on the 3rd core competency of enhancing population health, addressing social disparities through community partnerships. Go to the next slide. These are my illustrious colleagues for this learning collaborative. 4 of us have been involved in the first session in this learning collaborative and in today's. They include Ariel Mather from National Center for Equitable Care for Elders, Ellen Lawton from National Center for Medical Legal Partnership, and Saki Cho from National Center for Health and Public Housing. And today we have 2 special guests with us today. Sue Joss, CEO of Brockton Neighborhood Health Center in Massachusetts, and Beth Robel, CEO at HealthLink in Indiana. And I want to especially thank our 2 guests today, Sue and Beth, who've taken time out of their days leading their organizations that are both on the front lines of this pandemic. I know here in Massachusetts, and I believe in Brockton, just a little bit south of where I am, we are about at the peak of the pandemic. This is a really perilous and stressful time, I know, for all of us right now, and I really want to thank both Sue and Beth for taking the time today to share with us some of their insights that I think will serve us well in the days beyond the pandemic that I know we are all looking forward to. Next slide, please. These are our beautiful faces for those of us who are not on the video. You can go one more slide, please. The learning objectives today are really, again, focused around building partnerships to address social determinants of health. We'll be talking about integration of services between health center services and services provided in the community. We will be really seeing concrete examples of how these partnerships contribute to delivery system transformation. We'll spend a little bit of time talking about the use of data to assess the impact of these critical partnerships. Next slide. For the agenda today, following this introduction, I'm going to very shortly turn to the first case study of the Brockton Neighborhood Health Center and the Vicente Food Market. And Sue Joss will give an overview of her project. And then I have prepared a few questions to extend the dialogue, and I would also invite you through the chat to add questions as well, and we'll try to at least cover some of the questions within the case study discussion. And then at about 2:40 p.m., we'll be moving to the second case study, and I will introduce Ellen Lawton, who will in turn introduce Beth Robel to discuss a medical legal partnership at Beth's Health Center in Indiana. And then we should still have probably around 15 minutes at the end if there are questions that are not asked during each of the case studies, and we welcome you to stay and ask your questions at the end as well. Next slide. I now want to introduce Sue Joss, who has been the CEO at Brockton Neighborhood Health Center, I believe, since its inception in 1994. She's led the organization from the pretty humble beginnings as a mobile unit in a parking lot to a multi-site health center serving more than 35,000 patients in and around Brockton, Massachusetts, which is about 35 miles south of Boston. The health center is now among the largest employers in Brockton, and Sue has played a real leadership role in the community, including the business community, serving as the chair of the Chamber of Commerce, participating in a number of economic development boards in the city. She's also the current board chair of the Mass League of Community Health Centers, the Massachusetts PCA. She is a board member of Community Care Collaborative, which is a health center-owned ACO in Massachusetts, and I'm also proud to say she is a board member of Capital Link. Sue, take it away.
Thank you, Allison, and thank you everyone for having us to talk about Vicente Supermarket collaboration that we had. Could you go to the next slide? So this is the main site of Brockton Neighborhood Health Center. We've been in Brockton for about 26 years, and this site is about 12 years old. As Allison mentioned, we serve about 35,000 patients. We're doing about 210,000 visits. Next slide. So our patient demographics, very diverse as most health centers are. The piece that I really wanted to highlight on this slide is the largest slice of the pie. The 32% of our patients are from Cape Verde, and we have a lot of patients from Brazil and Haiti as well. But the Cape Verdean connection is what really led us to the collaboration with Vicente's Supermarket. Next slide, please. You can skip the payer mix. Thank you. Next slide. So you can see that we've had really rapid growth over the years. This is the last 20 years of growth. And right around 2013 or 14, you'll see that we were at 143,000 and then jumped to 163,000 visits in 1 year. That led to a really significant space crunch And we started looking around for where we might expand. Capital Link did a market assessment for us and recommended that our next site expansion still be within Brockton because that seemed to be where the primary need was. Next slide. So this is some, oops, could you go back one? Thanks. The slide that you saw with the, there they are. This is some of the Vicente family. And Vicente's market opened the same year that we opened our health center 26 years ago. They started with the dad in the middle who opened a convenience store, 1,500 square feet. And the health center and Vicente's market for many years were the two fastest growing businesses in Brockton. So they expanded on the other side of town to a full service supermarket. And like us, right around 2013 or 14, they had run out of space as well. And they had actually been working for several years to try to figure out a financing opportunity to rehab an old A&P market right near our current health center site. So they had they came into a community meeting in 2013, I believe it was, and they were all excited because they thought they had finally found a funding partner, someone to go in on the space with them and share the expenses so that they could actually rehab and open this market near us. Next slide. So we asked them, the group, we were all excited for them. We asked them who their partner was, and when they said it was McDonald's, we had a group groan, and everyone in the room, there were a bunch of community health partners in the room, said, you know, we're really glad you're expanding, but does it have to be McDonald's? All the work we had been trying to do to address health disparities, and you know, what we knew was that McDonald's was putting sites in low-income areas, and that diabetes and a number of other health related health issues were skyrocketing near the McDonald's locations in our state. So we really didn't want this to happen. So we asked the Vicente's family, what do we need to do to prevent you from going with McDonald's? And they said, well, find us another partner. So we had just started looking for additional space, and within 3 weeks, we were able to get our board approval at the health center to go ahead with Vicente's and be their partner on the space. Next slide, please. So this is Jason Barboza. Jason is one of the owners, and by the way, it's a dad, 3 sons and 5 nephews. So Jason is one of the nephews, and he was really the primary contact during this expansion project. So you can see in the background the very first rough architectural drawings of what this space would be. By the way, just as a comment, Jason and I have been on the phone all day today because we're in the middle of testing his 170 employees for COVID, as they are the outbreak site in our community right now, with at least 12 of their workers positive. Next, please. So this is opening day. At least it was opening day for the health center. I think the Vicente side opened a few weeks earlier than us because of a variety of regulatory hoops that we had to jump through that they didn't. But what we ended up doing is on the right, you'll see the Vicente supermarket. That was the old A&P. It had been vacant for about 20 years, been used as a warehouse off and on, but mostly was a vacant space located within a federally designated food desert. And the health center side on the left is new construction. So the two buildings are attached, but they do not have a joint entrance because just architecturally it didn't work out. One of the things that we wanted to take advantage of in this collaboration is nutrition. We had for many years been offering dietitian nutrition visits for our patients, but really had never formed it into a major department or initiative. So one of our priorities was to put a teaching kitchen into our side, and we wanted it right up front, so you can't see it too well in this picture, but it is right in those front windows, the teaching kitchen, because we wanted customers of Vicente's to be able to see what we were doing in the teaching kitchen as they were going in and out of the market. Next, please. So we were also worked very closely with Vicente's family in the design of the supermarket and work with the architects as well. So one of the things that was really important to us is as you walk into Vicente, the first thing you have to walk into is the produce section. And we worked with them on the signage up on the walls, really wanted produce to be a focal point so that our community would benefit from the education of having local produce available to them. Next. So Vicente's really is trying to stay true to its roots of the community. So we have Cape Verdean, Brazilian, Portuguese, Haitian, and so they have their import license and they are importing produce and going to the produce market every day and getting locally grown produce as well. They also have an ethnic food section where they're importing directly from a variety of countries. So this is the aisle of produce that's all of the root vegetables from the various countries. Next. And of course, we had the big grand opening. It's obviously Elizabeth Warren and the Vicente's family surrounding, doing a tour of the market and the health center. She was the keynote speaker at our grand opening. Next. One of the things they added was fresh fish. In their other market on the other side of town, they did not have fresh fish, and that was purely a space issue. So now they are getting fish right from the boats off of our shores. Next. And also another comment on the fish, the Cape Verdean and the Haitian cultures are, their diets are very fish-based. So as we've been working with, we have 2 registered dietitians, being able to send the patients right next door for fresh fish has been really a huge benefit. And you'll see here they also have an open churrascaria type roasting pit for meat. So they're trying to make the whole market look, focus on the healthy food, a lot of education about healthy ways to cook, and you'll see in the next slides really leading them in the direction of some of the healthier foods. Next. Next slide. Okay, so this is our teaching kitchen, and as you can see from this view, it does look right out to the waiting room. So I'm sorry, not the waiting room, the parking lot, so that when customers of the market are loading up their groceries, they can see the cooking classes going on. And what we're doing in the cooking classes, you'll see up front, we have community health workers who are multilingual. Some of our cooking classes are happening in multiple languages, although they've gotten so full that we actually have mostly branched out to do one language at a time now. But what we're doing is with the diabetic patients with cardiovascular risk, doing cooking classes that are very tailored to the cultures that we're serving. So the dietitians are modifying cultural recipes, not trying to change their traditional flavors that make them healthier. The community health workers are translating and guiding and educating. And then after the classes, they are taking the patients next door into the market and teaching them how to shop. So showing them where the fresh ingredients are, helping them with canned products to choose what is the healthiest pieces of it, and really just trying to one-on-one guide them through making healthy changes in their diet without giving up the ethnic flavors that they value so much. Next slide. So that's just a piece of the cooking education. Next slide. And next slide. So we have, this is a little bit dated slide, but we have actually even more programs going on right now with the group education. There's a number of things that are happening in the cooking classes now. Some of them are straight cooking classes, like so you'll see the DASH diet. We're doing a variety of things like that. But then you also see below that the diabetes basics, diabetes follow-up. We now have cardiovascular. We also have a cooking and recovery group for our harm reduction clinic patients. What we've done is we've teamed up a medical provider with a registered dietitian and often a social worker, behavioral health clinician into the classes as well. So they are getting actual one-on-one medical visits, going right into the group, and then getting diabetic education, getting social services support, and the cooking classes all in one setting. And that has been really just a hugely successful program for us. We have trouble keeping up with the demand for that often. And we have seen some real results, especially around our diabetic patients. We've seen consistently A1C levels go down and stay down after going through these courses. The courses generally are anywhere from 4 to 8 weeks. There's a variety of options available, but we have been measuring A1C levels and seeing, roughly 85% of our patients have drops in A1Cs and keep them there. Next slide. This is just another one of our advertisements about our programs. Next slide. One of the things we've launched on recently is we have one of our physicians who is passionately into trying to convince our patients to avoid sugary beverages. So that's our most recent campaign is eliminating sugary beverages from diets. And I think everybody knows the health impact of that. So we're doing a lot of multilingual, multicultural educational pieces. The classes are adding that component in. We've had actually a focus, and we were about to, before COVID hit, really launch this in a much larger way with our own staff, because I'll go into our staff cafeteria to pour a cup of coffee, and invariably the staff next to me will be pouring 12 or more packets of sugar into their coffee. So we're really focusing on our employees on this one as well. Next slide. This is one of the education efforts that we did right within the market. So these signs, these are actually plastic Klingon signage that was put all over Vicente's supermarket in a variety of languages, and they all point toward produce. So the idea was just to make the customers more aware of the produce section and try to point them in that direction. That signage has since been taken up, and what we've replaced it with right now is we've got shelf tags, which are these little signs that wiggle, and we put them near the healthiest foods to try to draw attention to the healthier foods. Next. So that was the end of my slide deck. I just wanted to take a minute also to talk about how this was all financed. Capital Link was really critical to this project, and in addition, LISC, we had new market tax credits both on the market side and on the health center side of this financing. So happy to take questions about that as we get into the question and answer session, but really just wanted to mention the new market tax credit is a really critical piece of how we pulled all of this off. So Allison, do you want to ask questions now or go on to the next?
Yeah, thanks, Sue. First of all, I want to invite any participants on the call. If you've got questions, feel free to type them into the chat, and we will try to address them, and I'll get started. Sue, I'm interested in knowing more about how patients at the health center sort of get signed up, if you will, for these programs. Is it do they volunteer themselves? Do your clinicians kind of prescribe it for them? How do they get hooked up into kind of the cooking classes? And it sounds like you have quite a team of staff who are focused on this. And I'm wondering if you can talk a little bit about how or if these services are reimbursed, and if they're not reimbursed, how do you support them through grants or other means?
Sure. So most of the patients who sign up are internal referrals from our primary care providers. We have 2 registered dietitians and 3 community health workers assigned to the nutrition program, and often they will go throughout the health center and just visit primary care providers and nursing staff to make sure that they are referring their patients in. We're getting reports on which providers are referring in, which aren't, and so a lot of times we'll go do outreach to those who aren't referring as heavily. In the joint medical visits, it started off with the primary care provider, who was the provider in the visit, they were recruiting from their own patient panel and then opening it up to other providers. It has evolved into a more open type of referral process where a primary care provider teamed up with the dietitian for, say, the diabetes program, will not necessarily be seeing mostly their own patients in the group setting, although it still tends to be more than half that way. So it has been kind of an organic. A lot of the patients, we actually have a hard time discharging patients out of the programs because it becomes a social, and that's why we have the diabetes follow-up, and we have a lot of patients just really benefit from not coming all the time, but from signing up, several times off and on to get re-educated for those programs. So, I would also say we also offer some of them to the community, the DASH diet in particular. That's very often open to our patients first and then opened up, if we don't fill it, to the whole rest of the community. On the reimbursement side of it, maybe Massachusetts is somewhat unique in this, but we actually get decent reimbursement on nutritionist visits, depending on the insurer, but we actually are able to break even at least on the nutritionist cost side of it. The community health workers are primarily grant funded, so we're always scrambling for grants to keep the community health workers fully funded, although in gaps when we don't have a grant, we haven't had to cut it off either. So it continues to be somewhat of a struggle.
So we've had a question through the chat that you may have answered part of it, but do you bill for the nutrition groups? I think that is a great way to get patients to come in and get chronic care management along with nutrition and social services. So it sounds like you are billing for nutrition visits, but how does that translate into the group? Is it the fact that the dietitian is there as part of the group that makes it billable?
Right. It is a billable visit. And very often we've also got a group visit that includes a medical provider. The medical provider is able to bill at the same time as the dietitian. So when that's working well, it actually covers the cost of the community health workers as well. And often the medical provider will pull the patient off before or after the group session for a brief one-on-one. But a lot of the pieces of the group visit are actually done right in the room. All the vitals are done by the community health workers right in the room. And a big piece of those billable visits are done by the medical provider. So we do get double billing available in some of the situations if we set it up properly.
Another question coming through the chat is, can Sue suggest sources of funding to fuel such a collaboration?
Well, if you're talking about the original collaboration of building the space, we found that in our case, we went through LISC for a new market tax credit. For the ongoing piece of it, LISC has been one of our grantors as well on some of this, but we have gone through I would actually have to get a list of the non-local grant sources. Most of it has been local foundations, so I'm not sure that there was much on a national basis that funded it, but I can get that list back to you.
Mm-hmm. That's great. And just for folks on the call, so Sue mentioned new markets tax credits, and new markets tax credits are a funding source that's primarily used for the capital piece, so the real bricks and mortar of the project. And I believe that both the health center side of the building as well as the market side qualified for new markets tax credits, which basically acts as a subsidy for about 22 to 25% of the overall project costs are paid for through these federal tax credits. So it keeps the debt amount on the facility much lower than it would otherwise have to be, and probably went a long way both for the market and the health center to make the overall project financially feasible for them. And new markets are have to be whether you can get new markets tax credits for an individual project is in part determined by the physical location. It seems like this location has originally a blighted building that had been vacant for 20-ish years in Brockton, which is pretty much most of Brockton qualifies as a low-income community, made this particular geographic location really ripe for that kind of investment. And a lot of health center projects across the country are located in exactly these kinds of communities that meet that are eligible for new markets tax credits. So it's definitely a good source to think about if you're considering something that basically takes a facility to make it work. I'm curious, Sue, to know how the collaboration with Vicente has evolved. And it strikes me that you were involved in terms of the first sort of layout and the emphasis at the market. But I'm also curious to know, like, how does Vicente feel about you maybe telling folks that sugary beverages aren't, shouldn't be on their grocery list and things like that? Have you run into any kinds of conflicts with the market as they are, seeking to run their market and you're seeking to encourage people to eat more healthfully?
They've been great to work with, and we have had to find a balance on that. Our dietitians, of course, came in and wanted to do a healthy front end, meaning removing all of the candy bars and sodas and everything from the front of the registers, and the market pushed back and said that's how we make all our money. So there has been that balancing act, but they've been working with us, and they're very enthusiastic. They actually have gone off to some healthy food conferences that we were able to get them participating in. They really want to be part of the healthy food solution for their customers, but at the same time, they didn't remove the soda and the candy. They did put next to the soda and the candy things like unsweetened iced tea and fresh fruit cups. So that was the balance that we've struck with them, but it is a kind of a work in progress.
Mm-hmm. Yeah, interesting. Have you been able, you talked some about the different, some of the clinical improvements that you've seen, particularly in some of your diabetic patients in terms of A1C control. And I'm wondering, does that get tracked in do you track participation in any of these, nutrition programs in your electronic health record? Are you using, any way to sort of systematically gather data on folks that participate and how it affects their overall health?
We're not gathering it as systematically as I want to, but the community health workers, right now it's mostly spreadsheet based, and that's not what we want going forward. But they are tracking beginning A1Cs, ending A1Cs a few months later. They're not doing it on all the patients. They pick certain classes and follow those patients, so it's not as robust as we would like it to be. We do have we are tracking things like what weight and cholesterol levels and that type of thing on the DASH diet, blood pressure, but it's a fairly manual spreadsheet based operation right now.
Mm-hmm. I think I recall you telling me at one point that there were some other aspects that you were trying to get started with the market, of some sort of like food point system or something that kind of like a loyalty card or something, but that would give points for healthy food choices. Were you ever able to get that going?
We were not. It's still on our wish list, but what we wanted to do is track patients' purchases and give them rewards for purchasing produce and other healthy food items. And the market's computer system just couldn't handle it. So we still have it on the list of things we want to get a grant for, but it just, the technical glitches kind of overwhelmed it for a while.
Mm-hmm. Mm-hmm. We're coming close to the end of our section of this presentation today, but I wonder if you might reflect for just a minute or so on what you think the most important factors were that led to the project's success, and conversely, if there were things that you, in retrospect, is there anything you would have done differently now that you're 5 years or so into this collaboration that you wish you had known when you started out?
So, I think one thing to mention as far as the success of it is that this whole thing was fairly accidental. That, Vicentes was looking for a partner and about to go ahead with McDonald's, and we had just started looking for space. So there was no real planning. It just was a kind of just go for it and do it because we need space and we need McDonald's not to be next door. So if I'd had to do it over again, if we'd had more time and really had been able to plan it out, I think more physical integration of the market and the health center, even though they're right next to each other, they don't have an adjoining door, and really just planning through how we really, have the teaching kitchen be part of the customer experience and all that. So that was just an option that wasn't available to us. I would say the piece that we were more hopeful for and that didn't come through is that the Vicentes family has been just hugely supportive of what we've been doing, but it's been, I would say, a fairly passive support. They're running a business. They're overwhelmed all the time, serving a lot of low-income customers. They're trying to keep their prices low, and they just don't have time to. We really envision them being part of our classes, and they're happy to have us tour our patients through, but they have been probably less active than we had originally envisioned.
Mm-hmm. I noticed on your website that the way this site is designated is Brockton Neighborhood Health Center at Vicentes, and it just really struck me how even the name of the partnership is so clearly, that's clearly how the community probably identifies this site as, oh yeah, the one at Vicentes. Right. And I wonder, do you think that how has that sort of co-location, do you think, affected business for both you and the market in terms of just foot traffic and patient flow?
So, I'm guessing it probably hasn't affected the market all that much because they are such an institution in Brockton, and they were at the other site, that I'm not sure that's changed at all. I think they're very popular, especially among the Cape Verdean, Haitian, and Brazilian communities we serve. It may have helped them shift some of their customers from their other site, which was just very cramped for space, more quickly over to this new site because we did give it a lot more visibility. It has helped us pick up a lot of new patients on our end because people will see the health center. And what we found is that the new patients at that site are very overwhelmingly of Cape Verdean background. So they are going into the market, seeing it, and stopping by, I think. So that's been good for our business for sure.
Mm-hmm. Interesting. Great. Thank you so much. This is a fascinating project, and it's great to get to hear about it, and congratulations on its really, I think, unique success. I'm not sure I know of another health center that has even though you wish it had been more intentional, but had, you know, intentionally co-located and successfully run some joint programs. That's really great. I appreciate that, Sue. And Ellen, now I'm going to turn it over to you and to Beth for the next case study.
Great, thank you so much, and thanks, Sue, for that really terrific overview of your work. And I know that there are questions that have come in through the chat, and we didn't get to all of them, but we will. We've got a little record of them, and so we're going to loop back. We're going to move through this case study. So keep those questions coming, and certainly while you hear from me a little bit, but mostly Beth, about medical legal partnership, we will be tracking your questions in the chat and responding to them as we go. So Chloe, if you could kick us ahead along these slides, which everyone, the PDF is going to be available for you in the handout section, and it's got some of these impacts. Keep going through the slides up to the medical legal partnership section, and I'm going to take hopefully no more than 2 minutes to just ground us in medical legal partnership, and I want to give you an opportunity to really hear a lot from Beth, her on the ground experience. Beth is similar to our previous speaker, longtime leader in the health center world, serves on the board of NAC, and also built up HealthLink from a free medical clinic, is that right, Beth, to a robust multi-site health center that is serving Northwest Indiana. And so you'll get to hear all about that work. I really appreciate Beth's leadership and passion and energy for tackling complex problems like the social determinants of health. And so, so just to ground us, we're going to be talking about another type of partnership, which is partnering between a health center and community-based legal services. And this is the work we do at Medical Legal Partnership, which is to help bring legal professionals into the healthcare setting to collaborate together and help patients resolve some of these complex social, economic, and environmental factors that contribute to health disparities. Next slide. And another quicker way of saying that is that medical legal partnerships embed lawyers as members of the healthcare team to help tackle patient problems, consult with clinical and non-clinical staff, and then leverage expertise to advance local and state policies. Next slide. And next slide after that, and then I'm going to kick it to Beth. So there are about 440 plus healthcare organizations around the country that are engaged in medical legal partnership activities. You can see about almost 10% or more than 10% of HRSA-funded health centers are our biggest piece of the pie there, which really makes sense because community-based public interest legal services are seeking to serve the same target population, low-income Americans who are struggling with a variety of different issues. And so we share mission and we share target population, and so we also share the opportunity to meet the needs of those patient clients where they're at. And so with that, I'm going to ask Chloe if you could advance the slides over to the Indiana. You'll get the benefit of those slides if you download the handout, and you can check out our resources on the National Center for Medical Legal Partnership website, but keep going until you hit Beth's introduction, and you can see we've got rich opportunities here for you to learn about MLP, and here we go, HealthLink. Take it away, Beth. Thanks for joining us. You're on mute. Beth, we can't hear you. Try it again.
Okay, now I am. Yeah,
right,
it would help
there you are.
if I was off mute. So thank you, Ellen. Actually, you're my hero kind of, and I'll talk about this in a minute, getting us started in this. You know, you never know when the right people cross your threshold, and about 4 years ago, Ellen was that person. So I'm very grateful. And Sue, I want to thank you for the presentation. I had no idea about the clinic right next to the grocery store. My senior team is very upset with you right now because I've been texting them, telling them one of our new sites we're looking at, let's go get with a grocery store. So thank you. So let me talk to you a little bit. Could I have the next slide? About what we've done here at HealthLink. I'm going to talk about, we kind of have a unique, I think, MLP, medical legal partnership, where a lot of times it's been focused on one group of people. We did it across all our sites, which I'll explain. The other thing is, I like to share too, is that I'll talk about how this is a referral, just like we refer to cardiologists or dermatology. MLP is right in that list in our electronic health record. I think that makes us unique, and it really makes it seem that it is part of our referral network. I'm going to talk about how we use it with Prepare, and then I'm going to talk some lessons learned on how we did it, and even some of the mistakes. Next slide. So now I got to do the disclaimer. We are on the, I like to say, the North Shore of Indiana. We are right by Lake Michigan, just to the left of where you can see where it says Calumet, and Hammond is Chicago. So one of our sites is actually 20 minutes from Chicago, and then we go all the way over towards South Bend, where Notre Dame is, and then we go down to a very rural site in Knox, where we have 5 counties, 11 standalone, 2 kind of shut down right now because all our schools are closed, school-based telehealth center, and a mobile medical dental van. And we include, just like a lot of FQHCs, we have medical, dental, optometry, podiatry, chiropractic, behavioral health, pharmacy, pediatrics, you name it. And one of the things we're most proud of is our medical legal partnership. Next slide. So how did this all begin? And this was pretty much a sad story. In May of 2016, we were already located in East Chicago, Indiana, which is, again, about 20-25 minutes from Chicago. And it was determined that both the public housing and a rather large school was built on an old lead smelter. And there was lead in the, all in the soil. And this had been going on for probably 40 or 50 years. EPA had gone in and made it a Superfund site right next to it. And as they investigated, the lead was in both the public housing and the school. I'll never forget the day it was after a NAC conference in Chicago, and we had come back because there was a big hearing with EPA and HUD and everything in East Chicago. And one of the city council women came to me and said, you got to do something. And I go, about what? What do you want me to do? I can't clean up the lead. And at that point, a lot of our residents and patients were being introduced to some attorneys that weren't probably the best, and had told them that they were going to sue the federal government and make them lots of money for all this lead in there. And we're actually picking them up in limousines, and a lot of times these were the first time the patients ever went to go in a limousine, so they thought it was pretty cool. And here they were told they were going to get rich, and she was trying to tell them that they weren't going to get rich. And so I said, let me see what I can do. And that's when we really got matched at first with the Indiana Legal Services. And about that time, I'd also attended an Association of Clinicians for the Underserved and met Ellen and heard her talk about the MLP. And we started to put the pieces together. So that's kind of how we got started. It was just for one little issue the lead and making sure the people, they shut down the public housing and moved. It was about, we lost 1,100 patients basically overnight because they were all moved out, but they were moved out all over the, outside of Indiana, Illinois, Michigan, some as far as Georgia. And we needed to work with them to make sure before they left, they understood their rights. Next slide. So this is how we did it. We as I said, we started with Indiana Legal Services, and we really built that partnership. First, it was just in East Chicago and just handling the lead. And then we started looking at what other things could we do. We established internally some a key staff person who was willing to learn more about this and to be kind of the coordinator. Then we started our education, and we still continue to do this all the time. We found examples of MLP besides the lead, and used what the attorney was using for our patients in East Chicago, but saw what else was out there. And we started communicating and got not only all our staff, but really the providers buy-in in that. And then we started to really look at how we could change things. So we try something. It's a big, for us that's in quality, it was really a quality improvement, but for the MLP program. And was able to spread, and I'll talk about this, not only have that staff person coordinate, but now we've added some additional staff that they work directly with the MLP. So next slide. And by the way, this again, I want to tell you, this was not overnight. It's been a 4-year journey, and we will start our 3rd year of actually having an attorney in July. And again, once we got East Chicago, we started to expand to our other locations. And the great thing was we could have the experience that we had in our East Chicago and be able to share that, so that we really got buy-in. And so we would do an orientation each site, and we also include what we do with the MLP at each of our new employees orientation, even if they're not directly seeing patient-facing. We've been surprised, even our billing department has been able to refer, because they'll have a patient that talks about, make a comment, I can't pay my bill because I can't pay my rent and I'm living, in a bad situation. And then they can say, we've got someone that can help you with that. So it's been really this huge expansion, and keep telling our staff over and over again, what are those good stories that we are hearing? We share it in our weekly emails that I send out, or we'll send it in our newsletter. We try to hit at least every other month in our newsletter some good stories of what's happened, and to give examples so that our staff can start to understand, here's some things that they might be hearing, and boy, our attorney, who's now named Sarah, can help you with that. We have added community health workers in there through a different grant, a behavioral health grant. And so they've been the champions of this too. Next slide. So how did we start to tie the social determinants to impact, our health and wellness of our communities? So we accepted probably about 2 years ago now. I think we've been on Prepare. First of all, it was we had it as part of our strategic plan to have 10% the first year of all our patients be screened for Prepare. And that originally we started with our community, with our nurses doing it. And then once we've added community health workers, they are doing it. We also can do it online. We have Freesia, which is our original patient registration up front, and that is in there too, so they can ask those questions. everyone is asked the prepare questions once a year, and as long, or it can be pushed out if there's some concern by provider or care team nurse. So as we saw that, we started to see which of the prepare questions would then fit in with our attorney questions. And again, this person is handling anything from, it's not criminal, but anything from housing. I'm going to tell you really recent with the COVID story, but one of my favorite, which was one of our first stories, was we had a woman, so the care team nurse was trying to work with her inhaler. She was asthmatic, and they kept switching the inhalers, and she was getting worse and worse and worse. And finally, the care team nurse said, you know, do you have a lot of dust in your house? And she said, oh, I don't have dust, but I have this black stuff on my walls. And she goes, like mold? And she goes, yeah. And she goes, and I'm being evicted because I complained about it. And sure enough, this woman I'll never forget, it was on a Wednesday that she came in to talk about inhalers, and her eviction notice was going to be on Monday, where she had to go to court, and she was scared. She knew she was going to be thrown out, and it was all because the basement in her apartment had flooded the summer before, and the mold had gotten there. The landlord never cleaned it up, and she complained, and so now he's trying to evict her. She can't, and I don't know if this is everywhere, but in Indiana, if you have an eviction pending or you have an eviction, you can't get Section 8 housing. So this woman couldn't even find another place to live. So she's got we're trying to deal with her asthma, but the mold is what's doing it. Immediately, she was referred to our attorney, and at that time it was Emma, and Emma went out, took pictures, went to court with this woman. When she showed the judge the pictures, he was appalled and went after the landlord and said, no, this isn't it. You've got to fix it. The guy actually turned off her electric that night, which then we had to go back to court to get that turned on, and then went back to court with that woman to get her deposit. So it was this big thing that otherwise, oh, by the way, and she was screened for depression, and she was very depressed. I would be too if I lived in that. So it's those other things. So then once we got her not having an eviction, she could go find a better place to live, and now she could get, we could talk about her asthma. But until that happened, we weren't able to. Okay, next slide. Yeah, so, you know, this is the other cool thing I think that is really neat. Anyone on the staff can refer to our MLP partnership. They can either do it through contacting our coordinator or a community health worker, or they can go online themselves through the EHR and do this. So there's multiple paths to the same result, is to get a referral to our MLP. Next slide. So there's many ways. Like I said, option one is, it can be, we could even have a patient ask. We've done a lot of patient education on this too. Can ask a provider, can I talk to them? We have care team nurses. We fill out a referral just to make it easier for our attorney. We can do a form and the release of information. It can be placed as an order under our in the EHR under legal services MLP, just like we do the cardiologist. And then the strategy manager can then, who is in charge of the MLP, can take that task and get it to the attorney. And then our ILS or Indiana Legal Services contact the patient and then completes their side of the intake. And then there's a feedback loop. You know, the other thing is through prepare. And again, like I said, the community health worker will look at the positive responses and see where they need some legal help. And then again, there's multiple, they can do the form, they can go into the EHR, but the bottom line is they all get to our attorney through Indiana Legal Services, and they contact the patient. And we have a lot of, feedback loops back and forth to make sure everyone's being taken care of. Next slide. So I think here's why we really wanted to get into our electronic health system is that we're very data driven. My staff, I drive them crazy every time they bring up something. I'll go, so tell me the statistics on that, tell me why, and show me the data. So this way we can actually track how many referrals we have. It's not on a spreadsheet somewhere, it's actually in the electronic health record. And again, and every time a provider goes in there to refer to anyone, he sees that there's this referral for MLP, and it's top of mind for them. We can then go back and say, tell me all my diabetics that have had a referral to our MLP, and we can start to see how that affects their health. And then it also links back to what we have in there for prepare. So it's been really helpful to see that it's all tied. We can tie it back to our SharePoint where we have a lot of data, but then we can actually write the reports. And I think that has been key to being able to keep, I've been able to tell my CFO why this is important. And we have gotten some grants for this, but some of this is actually self-funded. And we believe that it's driving our health outcomes, which, whether you talk to a managed care entity who has quality requirements for, each of one of their plans, or our, that asthmatic would not be controlled if we hadn't have intervened with our MLP. And that is reported through the managed care entities too. So multiple reasons. It's this, it's based in quality right now, but it's also based on what we do for our patients and things that we have not been able to do in the past through this. Next slide. So this shows our first year, we had about 334 referrals, and that ended up, and there's some referrals that either were quick finish fixes, or some of them are not handled internally. They're sent off. A lot of the immigration issues that we've seen have been sent out to Indiana Legal Services. They have a whole division that's all they handle is immigration, and they handle it. But we were able to serve in 2018 157 patients, and then last year it looks like it's been a drop, but it's just how we've got more referrals, and we were able to handle about 147 patients in some capacity. Next slide. And so again, we're using that community health worker to also be the coordinator to make sure that anything on that prepare is taken care of, but also they work with the MLP attorney to make sure that we're closing the loop, whether it's back with the provider or with the patient on there. And that's been really important to keep this program going. So next one. So, I really thought, oh, this COVID's going to happen. And I'll be honest with you, I'm in the office today, but normally I only had to come in because it's payroll day and I had to meet with the CFO and sign checks for other things. But normally I'm working at home, and I thought, well, there it goes. But actually our attorney is working from home. And one of the first, on April 1st, she got a call that we had a 60-year-old woman who was with disabilities and had a heart condition. And she received a letter that day, and we were already in a stay-at-home order from the governor that her mobile home community was going to be shut off, which included she had to get out. They were going to barricade the entrance, and if you stayed, you were a trespasser. she couldn't move. We're at a stay-home order. She couldn't go out and find a new place, and she was going to become homeless and have the possibility of being exposed to COVID-19. That was, she had called our office about getting her meds refilled, and she mentioned that. The staff referred her to our MLP attorney, and Sarah first went to the mobile home management, who didn't help very much. She went to all the health departments. She thought this was going to be a really quick fix, and it was amazing. It took over 24 hours, but she got it done. They made sure they talked about the COVID-19 protections, about, you can't throw anyone out, you can't evict anyone right now. She threatened to file a complaint for damages and get relief from the management and our attorney. And sure enough, they came back and also talked to the state. And the client is now able to shelter in place, which is where she needs to be, and not have to be out on the street in the middle of this COVID-19. So my story, there's many success stories, but that's one that really, even in this time where things are falling apart and it seems like that they couldn't be doing a lot, our attorney continues to work, and probably is a more important time for our patients is through this COVID-19. Next slide. I think that's it. So thank you for listening.
Great.
Like I said, this is a journey. So, just start little. That's my story. Start little, and then you can see it grow.
Great. Thanks, Beth. So much. And we have a bunch of questions coming in, and I'm going to try and I'll feed them to you, and we can kind of brainstorm. And so the first question, and I always get this question, of course, is how are you going to pay for this? And you tackled that a little bit, but you also had some conversations about, so if you can talk specifically about that, and while you do that, I'm going to post there's a financing issue brief that the National Center did last year that talks about different mechanisms for financing, and there's lots of creative ways, and you and I have had those conversations about how can you use a substance use disorder grant from HRSA to cover some of that time. So if you could just share more specifically some of the financing.
So we started with this one county foundation. It's called Legacy Foundation, and they basically paid for the East Chicago program. And then when we expanded, we actually found out that I had some money. We used it with our opioid grant for part of it. The other thing is our state Department of Mental Health and Addictions has a ton of opioid money. And so we went, and it's interesting, the head of the Indiana Legal Services, who has actually written a white paper on how MLP can affect the people with substance abuse disorder, has become the head of the State Department of Mental Health and Addictions. So when we've met with him, I remind him how important MLP is, and then his staff, I've actually given him the white paper. So they are willing to give us a lot of money. And I think that's it. And I could probably speak the whole time on just how this can help with the opioid issue. But yeah, so we've been able to leverage every bit. And then there is the money that we just said, this is worth an investment for our patients. And to be honest, part of it is in our quality outcomes too. So multifaceted. I think if you get it started and you start small and you can prove your outcomes, then the other grantors will come in. But again, I would check your opioid money in your state.
Right. And there's no charge for services when patients use them, correct? That is another question that came in. Right.
No charge. Yeah. And stuff. And so, I look at like that woman that I said that one of our first clients that was being evicted, it would have cost $6,000 for her to hire an attorney. She wouldn't have done it.
And there was, and you sort of answered this globally, but there's a specific question: what is your data on how these referrals and services make improvements to health outcomes? So I don't know if there's anything else you want to add there, or more specifically.
Yeah, and we're working on pulling, like, our A1C of our patients, or our controlled asthmatics numbers now. The issue is always, if we don't do this, they're not going to get, we can't even discuss those things, their asthma or whatever, until we fix those social determinants. So I don't have like 25% yet of our asthmatics improved because we did this, but we're working on that.
And I can say from a National Center perspective, we do have some of that data. There's, in particular, there's a great fact sheet that we did with National Healthcare for the Homeless Coalition on veteran legal services that costs out and looks at some outcomes in terms of being able to be compliant with meds, and the link between housing and mental health stability on a couple of different metrics. And so some of that, I think you can extrapolate from some of that data to your own population. So,
yeah. And I have more, I just thought something too, I didn't mention two things. Number one, I think it has helped with provider retention and satisfaction, because this was a dark hole that they felt like they couldn't do anything about. Now we're giving them that. This morning I was interviewing a resident at one of our residency that's in our area. We're recruiting her. And so I started explaining this about it. She got, oh my gosh, that is so cool. So I think it is actually putting us maybe a little ahead of others in the recruitment, if we can talk about it. It's kind of like integrated care used to be that, but now I can tell them about our MLP.
I think I'm glad you made that point too. And we actually, on that score, we had run some focus groups with clinicians about a year ago. The National Center did. There's a white paper on our website that talks about exactly that, which is that clinicians feel like they have tools to tackle problems that they felt like were in their right there in the waiting room with them, or right there in their clinical setting, but that they weren't able to address. And now having the NLP as part of the team, and I think you've talked really eloquently about just like cardiology, for example. So the lawyer doesn't see everybody, they don't treat everybody. There's a robust screening and capacity building infrastructure that you've created to allow everyone to work at top of license. So I think that's an important message as well. So, great. Thank you so much. And I think we're at time in terms of our section, and I know we left some questions unanswered. I think we've tackled all our questions that came in through the chat for Medical Legal Partnership, but maybe we want to double back with Sue and Allison, because I know there were some questions that came in from there. So, Allison?
Yeah, great. Sue,
great.
Are you still with us? There are a couple questions that came in about the grocery store collaboration.
I'm still here.
One question was, great. One question was, what age groups come to classes most often, and is daycare an issue for people to participate?
So daycare has not been an issue. Most of the patients, I would say, are elderly because of the diabetic focus that we've had, but we do have patients of all ages within the adult group. We have not done any pediatric groups.
Okay. There's another question about kind of the key takeaway. I guess the question is really about, do you have any reflection on what's made the most difference, and or maybe what has been the most popular, as in between the questioner says cooking classes, nutrition info, shopping experience? You have a sense of like, what do you think both adds the most value, what do you think the patients really value most?
I think the patients love the joint medical nutrition visits because they've got their own primary care provider in the room, usually for an hour and a half. Occasionally it's a 2-hour session. They're getting cooking classes at the same time, and they're also taken shopping at the end of all of it. But I think having the primary care provider there in the sessions and having really big chunks of time with them to talk through questions and lifestyle and wellness issues has been really huge. And I would also say this has probably been one of the best things we've ever done for primary care provider job satisfaction. They love doing the groups. It's just for the same reasons. It gives them a lot more time. They can hand pieces of it off to the dietitian, and they see their patients making real improvements on things like A1Cs, weight, blood pressure, that type of thing.
Mm-hmm. Interesting. Another question was noting that that Brockton is an area of high risk for lead poisoning. Wondering whether you've made any kind of connection between sort of some of the nutrition classes and linking, dealing with lead poisoning and nutrition at all.
We have not. We have very strong linkages with various local organizations around lead poisoning. We're testing all of our kids. We do have one of the dietitians who does one-on-one pediatric sessions with kids with lead poisoning, but we have not done anything in the teaching kitchen or in joint sessions.
Mm-hmm. Okay, thanks. Another question was, is the Vicentes market, or the folks who own the Vicentes market, are any of them on some sort of advisory board or have any kind of leadership role with the health center?
No, we tried that, and they're just too busy. We tried to get one of them on our board. They certainly are available for informal questions, but they're just, it takes a lot of hours a week to run a family grocery store, and they just haven't had the time.
Mm-hmm, mm-hmm. And then I think the last question was, I'm trying to find it here. There's another question on kind of saying more about new markets tax credits and also opportunity zones. I'm trying to find the question to find the specific how the person put it. Please say more about new markets tax credits, and on a similar theme, have your partners used opportunity zones? If you want me to tackle that one, or if you want to say more about
maybe. So you're the expert, but one just brief comment on new market tax credits is this is our second new market tax credit. Our first one was on our main building, and we got through the 7 years, and it unwound, and we really did get a whole bunch of money back at the end. So we're a pretty big fan of that as a financing mechanism. And Allison, you're just the expert on the rest of it, so I'll turn that over to you.
Yeah. I personally, and from what we've seen in our work with health centers over, the New Markets Tax Credit Program has been around since the very end of the Clinton administration. I think it's the most important financing tool that health centers have for capital projects. It's a federal tax credit that essentially contributes about 22 to 25% of the project cost can get covered by these tax credits. And so what Sue was talking about after 7 years, the money kind of coming back to the health center, what she means there is the tax credit compliance period is 7 years. So what that means is that during the 7 years, the tax credit contribution is structured as a loan to the health center, but it's typically at a very low interest rate, at 0.5% or something like that, interest only for 7 years. And at the end of 7 years, there's a a mechanism called a put-call mechanism, where essentially the tax credit investor forgives the loan. And so at that point, then that 22 to 25% that was originally funded by the tax credit investment effectively becomes a grant to the health center, so that what had been carried as a loan on your books gets basically wiped off your books and becomes a grant. So it's a tremendous subsidy for capital costs. It's equivalent of going out and raising 22 to 25% of your capital costs with a capital campaign, except you don't have to go through a capital campaign. So a lot of health centers have been able to finance their buildings that way. Another thing I'll say about the tax credit, the New Markets program, is that you can also take grant funds that you've gotten from HRSA or foundations or through your capital campaigns and use them, pair them with the tax credits to basically get more tax credits. So there are health centers out there that have essentially used the tax credit program and grants to fund 100% of their capital costs. So it's a very cost-effective way of making a major capital investment. And I think this example, this combined grocery store and health center physical facility, I think, Sue, you might have to correct me if I'm wrong, I think it was around a $22 million project. So, and so a quarter of that, roughly a quarter of that cost, got paid for by the tax credit. And without that subsidy, I don't know whether either the health center or the grocery store would have been able to afford to do that. Someone asked a question about opportunity zones. Opportunity zones are a more recent kind of federal credit that was just put in place actually just a couple of years ago. It is, in my book, not even close to the value of New Markets tax credits. Unfortunately, I think the benefit to low-income communities of the Opportunity Zone credit has not yet been proved out in my book. I think it basically is a credit that was made to incentivize basically venture capital. And there are real issues of, if you use Opportunity Zone credit, it does put money into your project, but then when the investor wants to exit the investment, health centers could be put in the position of needing to buy back their own building at an appreciated price. Unlike the New Markets program, which after 7 years, that tax credit equity gets put back to the health center and you keep the equity. In the Opportunity Zone program, basically all of the incentives are for the investor to keep the equity. So it's not nearly as good a deal unless you happen to have a friendly investor that's willing to basically forego their gain in the credit and donate it somehow to the health center. We have not actually seen any examples of that in the health center world.
Thanks for that. This is Ellen. Thanks for that, Allison. Very helpful. And I wanted to hop in because we got another question in the chat, also about money, right? Because no margin mission, and so folks are asking, similar to the questions for you and Sue, for Beth and I to talk a little more about who's paying for these attorney services, right? And like I said, we have resources on our website, so National Center for Medical Legal Partnership, but also know that there is a national network for the folks on the healthcare side or the public health side or the payer side on this call. It's a national network of public interest attorneys that are part of the legal aid network that's very similar to the health center network. And so I think it's 180 legal aid offices around the country that are federal funded, just like health centers, to provide these basic services. But they're overwhelmed, and by linking up with their health center partners are able to be more efficient and effective in the work that they're delivering and be at top of profession, as Beth had referenced. And so really encouraging you again, like Allison and Sue talked about, and Beth referenced, being very creative in how you think about the financing for this work. That you can include these services in a range of different, traditionally quote healthcare-based buckets of financing. And in thinking about it from a team perspective, right, that as Beth had said, and invite Beth to hop in with any additional comments, if I'm going to help somebody who has asthma, I actually need a lawyer on my team, as well as pulmonologist, access to a primary care physician, et cetera. So Beth.
Yeah, we've been able to, like I said, we've been going to the different community foundations to get some funding. And then the big one was our opioid grant and our behavioral health grant, and being able to include it in that.
Yeah, as part of the team. So calls for creativity, and it calls for starting small, like Beth said. But we certainly see that around the country, that there are lots of different ways to figure out the financing. And lots of experiences that we detailed on our website. So I think with that, we're coming to time to close out. And so, Chloe, are you going to close us out with any comments on the survey, et cetera?
Yes,
before we get there, I just want to say, thank you to our panelists for your energy and leadership and sharing your insights. Really appreciate that on behalf of the SDOH Academy. Chloe, take it away.
Thanks, Ellen. And I would like to remind everyone that there is a very brief survey that will launch once this webinar concludes. Please take 2 to 3 minutes to fill in your answers, and this will help us greatly for the program in future webinars as well. As Ellen said, thank you to all of our presenters for an informative session today, and a big thank you to all for your time today. Stay safe. Thank you, everyone.
Thank you.
Thank you.